Hey, hi everyone. Thank you for joining us tonight. I'll hand over to Alex in to get us started.
All right. So we might just get started. There might be a few more people join us in a few minutes. So, firstly, good evening and welcome to the first second part of the year of ECHO for type 2 diabetes in far western New South Wales. Western New South Wales, PHN, and all of us here acknowledge the traditional custodians of the land throughout Western New South Wales and their connections to land, water and community. And I pay my respect to elders past, present and future and extend that respect and a warm welcome to all First Nations people present today. I'm of course on Wiradjuri land. And tonight we've got our panel. I'm Alex Hole, I'm a GP in Molong. We've got Dr. Manik Mayaduna, he's an endocrinologist at Orange. Alison Amor, credentialed diabetes educator, and Amanda Taylor, credentialed diabetes educator and pharmacist. Martin Watson's away today. Strongly encourage you all to leave your webcams on. It helps us to feel more part of a community and together. And however, please do leave yourself on mute unless speaking. We do live and work in small communities and sometimes we are able to identify the patients being discussed. If you do so, please maintain confidentiality. Questions are welcome. Use the hand up or type it in the chat and I'll read it out at the appropriate moment if you're not feeling comfortable to talk. But we do encourage you to, unmute, put the camera on and voice any questions you might have. As always, a reminder that our language matters when discussing diabetes. The words used to talk about diabetes affect the physical and emotional health of people living with diabetes. They also affect how people in society view people living with diabetes. Our words need to show that we care and remove bias and blame. So you might ask yourself, people with diabetes call themselves diabetic, so why shouldn't I? Well, evidence shows that 1 in 2 people find the label unacceptable and 1 in 4 find it harmful. People with diabetes are free to use whatever words they wish. Other people, especially those of us in healthcare, have a responsibility to engage all people affected by diabetes in positive and helpful ways. And without further ado, I might hand over to Manik, who's going to present tonight's didactic presentation on chronic kidney disease.
Thanks, Alex. I'm just going to hit share here. Here we go. All right. Hopefully you can all see my presentation there. Is that coming up on your end?
Yep.
Lovely. Excellent. All right, so I'm going to be talking about diabetic kidney disease. For those of you who don't know me, my name is Manik Mayaduni. I'm an endocrinologist at Orange Hospital and also in the general medicine department there. So this is a talk I've given before, but I think it's always relevant and I think we don't think about diabetic kidney disease probably as much as we should as a community. So I'm going to go over this and please, if you have any questions, do write them down. We can talk through them at the end if time permits. All right, so an introduction. So I'm sure plenty of you have lots of patients who have got chronic kidney disease, and diabetes is the leading cause of chronic kidney disease and end-stage kidney disease in Australia as well as worldwide. In terms of the numbers, these numbers were from a few years ago and will have escalated from there, but 330,000 people have diabetes and chronic kidney disease. So that's a huge number and it's a large chunk of the morbidity attached to diabetes. About 10,000 of those people will require transplant or dialysis, which are then attached to their own complications and morbidity and limitations on quality of life. And that makes up about 37% of those people with end-stage kidney disease. So those are people with diabetes. So suffice to say, it's a large chunk of people that we're managing within the end-stage kidney disease population. A large proportion of people with diabetes will also go on to develop some stage of chronic kidney disease. And I guess the point is that if we know that 40% of them are going to progress to this, then we probably need to be proactive and act early before they get to the end stage. And I want to just really emphasize that chronic kidney disease is a cardiovascular risk factor, and I think we need to frame it that way in the same way that we look at hypertension or hyperlipidemia or smoking. This is something independently that we need to try and optimize. Now, this diagram I think is really useful, going from no chronic kidney disease to end stage, looking at how that affects our mortality rates, but also complication rates. And from stage 3A onwards, we can see that a whole bunch of these cardiovascular outcomes become more prominent, and we probably don't think about them all that much. So like hemorrhagic stroke, valvular calcification in the heart. So there's all these extra morbidities that move through stage 4 and stage 5 chronic kidney disease. Now, how do we define it? So either an eGFR of less than 60, but you can also have chronic kidney disease with an eGFR above that if you have an elevated urine ACR. And that elevated urine ACR is an early marker of diabetic kidney disease as well. The term diabetic nephropathy is not technically synonymous with diabetic kidney disease, and it's reserved for those who have got progressive albuminuria rather than primarily an eGFR drop. What are the implications of chronic kidney disease in diabetes? So frailty, reduced quality of life, end-stage kidney disease and dialysis, and mortality. And each of those have, multiple complex layers to them. In terms of the pathophysiology, so it's driven by reactive oxygen species, which then causes endothelial dysfunction and inflammation and apoptosis. I guess that inflammation is important in that we know that chronic inflammatory diseases cause atherosclerotic disease, and in the same way, there's probably some overlap in this inflammatory process and how that mediates cardiovascular events down the line as well. We get microvascular kidney injury. We initially get hyperfiltration to try and compensate for the kidney damage, but over time, basically, the nephrons tire out, and that's when it leads to more permanent failure of tubular function. And then we get fibrosis in the tubulointerstitium, and again, that fibrosis complicates the decline in function. Now, I think modifiable is a really key word, and I try to focus on that every time I see a patient. I go, well, okay, well, these are your risk factors. Some of them you can't fix, like what your mum gave you. Your genes are your genes, but here are the things that you can actually change. So I think we need to emphasize those and focus on those in our conversations. So hyperglycemia, hypertension, hypercholesterolemia, weight gain, and smoking. In terms of testing in diabetic kidney disease, so the urine ACR is really important, and we should at least have annual testing, and that should ideally be a morning first void spot urine. Now, there are lots of variables that can complicate this, so infection, fever, exercise, so there's a whole list there, but the point being that you don't want to, well, you shouldn't be testing if you want an accurate result when you've got any of those variables. So oftentimes when patients are admitted under my care for general medicine, I won't check their urine ACR because it's not accurate. And that's why I'm going to apologize in advance if I send them your way into the community without checking and add it onto your list of things to please follow up. That's why, because it's not accurate in the inpatient setting. So we need to repeat it at least twice within 3 months to diagnose it, and if at least 2 of those readings are elevated, then we can say they've got albuminuria. In terms of eGFR, so if it's less than 60, and this is a new finding, then you want to repeat it in 7 days to make sure it's not acutely declining, because that could totally change your management. And then if you know that it's stable, you want to repeat it twice within 3 months to make sure that that is accurate. And if you've got 3 times eGFR, which is less than 60, then you can call that chronic kidney disease. We need to consider other causes. So these are the things that I want you to sort of frame this question within, in that diabetes is so common, chronic kidney disease is so common. Just because they've got diabetes and chronic kidney disease or even acute kidney injury doesn't mean that one is due to the other. So they might just have diabetes and have another process which is causing kidney injury. And so these are the clues that suggest, well, hang on, maybe it's not because of the diabetes, because diabetic kidney disease is a slow progressive process. So if they don't have any retinopathy, but they've got significant renal impairment, then it's probably not diabetes because the retinopathy should occur concurrently with diabetes. If it's less than 5 years disease duration, and that's not the same as 5 years since diagnosis, because people get delayed diagnoses. If they've got an acute kidney injury, hematuria or other systemic diseases, particularly rheumatological diseases, and nephrotic syndrome, we need to ask, is there another cause? In terms of testing, this is a really nice table you guys have probably seen before. So we look at the eGFR, we look at the albuminuria, and then where they intersect in this table gives us an idea of how that correlates with cardiovascular risk. So if you have really high macroalbuminuria, even if you've got an eGFR above 90, you have a significant cardiovascular risk associated to that. And similarly, you might have a normal albumin, but if you've got an eGFR which is stage 5 kidney disease, then you've equally got a terrible cardiovascular prognosis. All right, treatment. So hopefully lots of people are doing this, starting an ACE inhibitor or an ARB. So that's the prils and the sartans. If they've got elevated blood pressure, people tend to start that sooner because I think we're just generally more familiar with these as blood pressure medications. But really, they're not just blood pressure medications. They're also albuminuria medications, and they're also heart failure with reduced ejection fraction medications. So we need to, again, unbox them out of the antihypertensive pack and call them, look, medications that could treat any of these things. An SGLT2 inhibitor, we know they have really good outcomes when added on to ACE inhibitors or ARBs. Finerenone, again, an add-on to those two, and that's a non-steroidal mineralocorticoid receptor antagonist. And that's fairly new on the market, so probably in the past 12 to 18 months that's been around. So hopefully it's starting to trickle into some of your practice now. And then GLP-1 receptor agonists, which a lot of our patients would benefit from anyway, but here's another reason why we should be trying to start those. And then managing their other cardiovascular risk factors, which we're probably more familiar with than the kidney disease. Now this is from the KDIGO guidelines, which I love, and I hopefully you all love as well, because it's a really clear approach to managing kidney disease. So on the left-hand side, we've got SGLT2 metformin. Now, depending on what country you're in, sometimes you might have the SGLT2 as first-line therapy, but here we have to add it on to metformin. All the cardiovascular risk factors down below that, and then addition of a GLP-1 receptor agonist to that, depending on whether we're achieving their glycemic targets or not. Then when we look at the blue boxes, we've got the RAS inhibitor, so ACE inhibitors, ARBs, and then stepping down, we've got the non-steroidal MRA, which is finerenone. And if we've got hypertension, which is unmanaged at this point, that's when we should be looking at other medications like dihydropyridine calcium channel blockers, such as amlodipine. And step down further below that is spironolactone, for example. And then a statin to manage the vascular disease risk. So we know that ACE inhibitors and ARBs reduce eGFR and albuminuria decline, right? So it's protective. There's no preference of one agent over another specifically, but what we don't do well is increasing to the maximum tolerated dose. So you want to be checking their blood pressures, and if they're tolerating it fine from a blood pressure point of view, gradually titrating to the max dose. And with each dose increment, monitoring their potassium, particularly if they've got spironolactone on board as well. So this is a nice flowchart of how to approach this, and that 30% change in creatinine is what we need to use as a threshold. So if it's less than 30% increase in creatinine, then that's tolerable and expected within the short period of time, because over the medium to long term, it will still amount to a protective effect in eGFR. And we need to think about other medications that might also compound both worsening kidney injury and hyperkalemia in that context. SGLT2 inhibitors. So we know that they make you pee out sugar, but there's also secondary effects which are separate from that mechanism, which protect patients with diabetes from progressive kidney disease and also from heart failure in particular, but cardiovascular events in a broader sense. we've got empagliflozin and dapagliflozin. I tend to use the dapagliflozin for those who haven't got established cardiovascular disease because that's what the studies were done in, and empagliflozin in those who have established cardiovascular disease because that's the population that was studied in. So we can also give it for heart failure with any ejection fraction. And we can give it for chronic kidney disease with eGFR between 25 and 75, and then basically macroalbuminuria. This is a nice little flowchart again from KDIGO. I won't go through in great detail, but it's worth referring to if you need some more structure. There's a bunch of kidney trials. So the DAPA-CKD and the EMPA-kidney are relevant to dapagliflozin and empagliflozin. And then EMPA-REG was the general cardiovascular outcomes trial for empagliflozin. This is the DAPA-CKD data, and basically we can say that we can demonstrate here that in all of the kidney disease outcomes, DAPA did significantly better and started to do better quite early. So we can see in a matter of months from commencement, we were seeing benefits. And that's the EMPA kidney data. Again, so this is percentage of patients who have had a kidney-related event, significantly lower in empagliflozin versus placebo. And then we've got a whole bunch of cardiovascular trials and heart failure trials for EMPA and for DAPA, which demonstrate benefit over placebo. Finerenone, so this is added onto an ACE, an ARB, or an SGLT2 inhibitor on top of that. And these are the criteria for PBS. We monitor the potassium like all MRAs, but it does reduce progression of kidney disease in diabetes as well as reducing CV events. And this is a summary of that data. Again, look, probably the magnitude is not as significant as the SGLT2 inhibitors, but it's certainly a clear benefit over placebo. And that was the other significant study, Figaro, so Fidelio and Figaro studies. And then the incretin analogs, so semaglutide was studied in the FLOW study, which demonstrated, again, benefit in protection against progression of kidney disease. And there's also been pooled and post-hoc analyses of the SUSTAIN and LEADER trials and the SURPASS trials, which have demonstrated, again, really a class effect in these medications. So if they can afford it, if they're appropriate otherwise, then here's another reason to put them on one. And this is just a summary slide of the FLOW study, which you can look up in your own time on the New England Journal of Medicine. But again, very convincing evidence that this is also protective against diabetic kidney disease progression. And that is all I've got. I haven't even looked at the time. I was trying not to breathe too much, so I'd keep it short.
Did well with spot on time, Monique. We've got 2 minutes for questions about the didactic. So type it in the chat or raise your hand or wave wildly at the screen, whatever works. While everyone thinks about their questions, SGLT2s you can use first line in limited circumstances in Australia now. So it is PBS listed for Aboriginal people or people with high CV risk. Just make sure you double check the PBS indication, but they have removed the prerequisite for metformin recently.
Yeah, sorry, I should have mentioned, Alex, and also what we should ideally be doing is co-prescribing metformin and an SGLT2 as both first-line agents.
I had a question. Are there any, I guess, ethnic differences in terms of diabetic kidney disease, thinking about non-white ethnicities?
I don't know of any, and I haven't seen any studies that have compared the outcomes in different ethnicities, but I would love to know that.
Yeah.
I mean, the fact that the PBS is now covering it for Aboriginal and Torres Strait Islander patients is, I guess, recognizing the fact that they've got higher cardiovascular risk, even if all other variables are accounted for. But I don't know that we specifically have a study to demonstrate in SGLT2s.
Thanks. There's just a comment. Thanks, Manic. All right. Well, if there are no other questions, and sorry for hogging all the time, everyone, we might pass over to Dr. Leslie Moran. She's a GP registrar in Molong. So thanks, Leslie, if you want to give your case presentation. Thanks very much to everyone who's come along tonight and for your participation in the series. Our next session is on September 11 with Dr. Alex Jones, a dentist with a particular interest in preventative dentistry, to talk to us about dentistry in type 2 diabetes, which I think will be eye-opening for all of us. We'd also really encourage you, if you've got any cases, tricky or straightforward, anything that you'd like to present to the group, please get in contact with Ali Sullivan. We're really always looking forward to any cases that you might want to present. Manic, sorry, you got a last word in.
Yeah. Last thing I just want to say, with the SGLT2 inhibitors, I just double checked. You still need to prescribe them if they're for diabetes in combination with metformin. So if they don't tolerate it, metformin, that's fine. If there's a contraindication, that's fine. You don't need it, but everyone else has to be on metformin as well.
Great, thanks, Manic. And Ali, sorry, is there a survey slide, or is it when they close the session will pop up for the survey? Can't remember. No survey tonight. There you go, guys. Off free tonight. We look forward to you all joining us again on September 11 for our next session. If the panelists would just stay online for a little post huddle, that'd be great. Thank you.
Thanks, everyone.